It is my privilege to introduce our next speaker. She has quickly become a mentor to me, and I'm thrilled that she is speaking at our conference. Dr. Erna Snelgrove is a registered nurse with 33 years of perinatal clinical experience. She graduated with her PhD from McGill University, and her area of research focuses on identifying ways to successfully implement evidence into practice in maternal, newborn, and women's healthcare settings. And her overall goal of this research is to change healthcare provider behavior and improve patient outcomes. Additional areas of research and practice include practice development and person-centered care. Erna currently works at Queen's University as a Vice Dean of Health Sciences and the Director of the School of Nursing, all while maintaining her clinical practice in labor and delivery. She clearly does not believe in downtime. Please join me in welcoming Erna to the stage.
Well, good morning. It is lovely to see so many faces this morning. Can you hear? I can talk loud. All right. That has not been a challenge. My challenge will be seeing my slides, but we can work that through. If you can't hear me, just put up your hand, but my voice can carry. I did learn in the old school of closed glottis pushing and counting to 10 and doing it very loudly, in the ear of the woman until knowledge translation came into my life and I realized it was time for best practice. One second as I figure out to move. There we go. This morning I am delighted to be able to share with you some examples, some topics that are near and dear to my heart. I wondered what it would be like following somebody who I have followed for many years as a labor and delivery nurse. And so it was a pleasure to do that. But more so a pleasure because the things that have already been talked about, I'm going to grow them. I'm going to talk more about them. We're going to talk more about evidence. We're going to talk about culture and context. And we're going to talk about beliefs and values. And we're going to look at the ways that those things, those concepts, have had an impact on the way that we practice as decision makers, as health providers, and as people that care for persons that are in labor. I'll disclose that I have no conflict of interest, financial, but rather I do have one personally, this topic. And it is a conflict of interest because if I was to give you all of Erna, the depth of passion that I have for this particular topic guides pretty much everything that I do. If you can get a little bit of the twang, I'm from Newfoundland, and in my beginning career, not that you need to know my whole life, but my first summer of university, when I was going to MUN, I got to work as a ward aide in the case room. The nurses, labor and delivery nurses, traditional, what most people hear, they weren't really nice. I had to stay behind the barrier doors. I had to wear a cap, OR cap. I had to wear a mask. I had to wear a full gown. At night, they didn't talk to me. And my mom, who's a nurse, used to say, just stay awake, get a cold cloth and dust if you can't stay awake. So I did all the things that Mom told me I was supposed to do. But then, as I mopped the floor after delivery, as I put the stirrups away because every woman was in stirrups, I thought, what are they doing there? I mean, I played with placentas, loved placentas, cut them, found Wharton's jelly, found Ava, found everything I needed to, pretended I was doing gases, washed all the instruments after the section, put them back together to go to CSPD. I did all of the things that were like, oh, I think I really like this. And then one nurse, one night, it's August, and she asked me if I'd like to watch a delivery. So totally non-person-centered. I went into a woman's delivery, don't know her from Adam, stood in the back of the room, masked just like everybody else, and watched the most beautiful thing I've ever seen. See, I could fill up in my whole life. And I knew that was it. So Mom told me not to be a nurse, Dad told me to be a nurse, and I applied to MUN. And I started in September, and everything I did in my career has been geared toward birth, and it's been geared toward best practice. I begin working, and I see that everybody is doing something completely different from what I was taught in school. We moved from Newfoundland to Halifax for just 1 year, and it was 29 years later, to watch 27 obstetricians all again do something different. I start my master's because I'm bored, and I'm tired of having to do something that I don't think is the right thing to do, and I'm just a nurse. And partway through master's, of course, I thought research was silly. So partway through my master's, this thing called research utilization hit me. And all of a sudden, it came to life. I could be a labor and delivery nurse, and I could use best evidence and improve outcomes based on the information that we have. And then the challenge was, well, how am I going to do that? Because when I walked down the hall, once I got my master's as the research associate, and my job was to help staff nurses use and do research in their practice, staff nurses called me the clipboard queen, and they went the other way. And nobody wanted to be part of that. Now, I shouldn't say nobody, but there weren't a lot that did. So for those that know me a little, and there's not many of you in the audience, I don't have much of a stop button. And if I truly believe that something is appropriate in the way we should do it, then I will keep going. And that's what I've done. So that's my disclosure of my passion. I don't think it will end. And I know that when I'm not here on this earth, that my work will continue because we won't have it all figured out even by that point. Knowledge translation. It's a term that if you've read the work by Ian Graham and Jacqueline Tétrault, I think there are 72 words that align with it, because concepts that we use all have different ways that we acknowledge them and different ways that we understand them. So I'm going to take a little poll, but I'm going to do it, I'll have you just read these three. And oftentimes, because people are hesitant to talk, one of the ways that a dear colleague of mine asked to get a classroom of students to have a conversation was to put your number of fingers up that align with, so everybody's hand will be up, so nobody is different from anybody else. So at the same time, please put your hand up and let me know if you think knowledge translation is sharing information, if you think it's more aligned with the second, which I won't read out, or if you think it's something different, depending on who you talk to. So 1, 2, or 3 fingers, please. I see 2s, I see 3s, I see a 1. I don't know who wins because 2s and 3s at this moment seem to be kind of tight in the race. Awesome. Thank you. That's great. When we get to the next slide, I'll be able to tell you. Is there a special way to point? No. Yep, there we go. So it was 2 for those that answered 2. Congratulations. And it's not that it isn't the others either, but it more aligns with 2, because according to CIHR, where Ian Graham was, I'll go with a bunch of acronyms, the VP of KT at CIHR, knowledge translation is a dynamic and iterative process. And what it is are these concepts. It's synthesis, it's exchange, and ethically sound application and of knowledge. Why? Because we want to improve health outcomes. Why don't we do it when we have the information? Those are the things that we're going to talk about. But it's complex because it takes place in a system that's messy. It takes place on a birthing unit, on the postpartum floor, antenatal, in the community, in an area where people bring different beliefs and values and experiences and knowledge. And all of those people, and I like to say that nobody wakes up in the morning to go to work to say, today I'm going to use bad evidence. Today I'm going to do all the things with the patient that I think are wrong. That's not the case. People wake up with the best of intentions, and most days they're in an okay mood, but sometimes they're not. But there are many variables that influence the application of their knowledge, their evidence, and how it takes place when we move forward. And I think this thing likes me. So just have a read. So I don't want you to use the evidence you learned in university, because by the time you graduated, most of it, except for information on episiotomy, is outdated. But I do want you to think about what is evidence, Because most times, and another colleague of mine, Shannon Scott and Carolyn Pollock, wrote an article about what is evidence, basically said, let's cut to the chase. Evidence means research, but evidence is not research. And if we have an evidence-informed practice, we have three things that contribute to our evidence. We have research, that's a given. There are all different levels, quality, and they all contribute in different ways, and we've heard a bit about that today. We have provider experience, evidence, in that context that we know makes a difference, and we have patient voice. And how many times do we not include the patient? How many times do we not share with the patient information about her pelvic floor and not give that person an opportunity to make a decision about their care? I recently did a talk with some pediatricians in Kingston, and one of the pediatricians asked me, well, what am I supposed to do when they won't do what I want them to do? And what I wanted to say, I had to hold back on, and what I said was, have you ever thought about having a conversation with the person that you're providing care for and see why they're feeling the way they do? Most people want their best health. They don't think that they want to do something to themselves to cause harm, but they too come with a package of beliefs and values that will impact the way that they feel. So what we have is a variety of choices about how we're going to transfer knowledge into practice. And I'm going to get a little bit academic just for the moment, because if we practice by this is what I feel, that's awesome, but it's not been tested. It doesn't have a track record, and it may not be the theoretical approach that we really need to use. So what you have before you right now are just a few theoretical approaches that are used for when we do research for translating evidence into practice. What I'm going to tell you is that the use of each of these is dependent on this. It's dependent on who you work with, when you use or how you might want to use this theory, how you're going to collect your information, and what resources are available. For me, I'm going to share with you the theoretical frameworks that I use that guide my practice in research for putting evidence into maternal newborn care, and they stemmed from meeting the authors of the framework and then deciding, I like them, and so if I like them, their work must be good. I think I'll try that out. We use things for different reasons. It is not that something is right nor wrong. We can think about shades of gray, and it's how you defend your argument. So it's the concepts that resonate with you and the concepts that make sense that you then can argue are applicable. Thank you. I think I go back just one. So one of the frameworks that I use is the Paris framework, and it's promoting applied research in health services. The reason I started using this particular piece of work is I went to something called Practice Development School in Oxford, England in 2002 with Alison Kitson. And when I heard her talk, I thought, oh gosh, whatever she does, I want to do. And so that would be the truth of why I started, but why I continue to use it is because of these three concepts. Because it's comprised of evidence, it's comprised of context, and then facilitation, which is the strategies we use to support the change of behavior. So we just talked a few minutes ago about what evidence is. It's research, it's clinical and patient experience, and it's local data. That's the provider experience. And while those pieces of evidence matter, they must be strong. They could be level 1, they could be a qualitative study that makes the difference. The thing that makes the biggest difference, and it's come from the work that I've done, is the context. It's the context where you're working, it's the culture, it's the evaluation, it's the leadership. If we don't have leadership support, things aren't going to make a difference. If you think about, if you've worked on different hospital units or floors, the way you learned to change a dressing in school may be different what you saw the first time you went out into practice and you saw somebody do it in another way. If you left labor and delivery and did something way X, when you go to the postpartum floor, you do it way Y. People have different practices. And again, some of them are more appropriate than others, but the context that we're working in makes a difference. Several years ago, I did a study at the IWK Health Centre in Halifax, and I looked at how evidence is used in each of the 5 care areas, looking at meso, macro, and micro. And it was very interesting because there was quite a difference across those 5 areas for the use of evidence. And the unit that reported having the best uptake of evidence within their practice is the unit where everybody worked together more effectively. It's the unit where the staff were happier. And by staff, I mean all healthcare providers that were there. And it was the unit where leadership spoke of the use of evidence on a regular basis. So these 3 concepts fit really well for me, but what was missing is the reason why I also use the theoretical domains framework. And that's a behavior change intervention that's based on theories where we look at things that are more effective because they have a theoretical base, developed by a variety of different types of researchers. And it's comprised of 14 domains. What's neat about this is that each of these domains, each of these areas that we uncover when we do focus groups and interviews, have theory-driven interventions that align with the particular domain. And it's not one intervention, but a suite of interventions that you would apply based on what's happening in that particular context, and you can try it out. Now, here is the 14 domains. So I said there's 14. I said there were theory-driven interventions that align with it, except for one. There is one domain listed here that does not have any interventions associated with it. Which is it? Any ideas? No, not optimism, but good. Thank you for trying. What's that? No. No, it's social, professional role, and identity. Think about it. It's how people work together. It's how people know what their respective discipline is. And it is the one domain that in every single KT study I've done is the one that stands true and rings the loudest every single time. Funny that is, people, messy creatures, that when we get together to work, all with the goal of improved health outcomes, can't find a way to work together to help that to happen in the effective way we'd like to have it happen. So I'm going to share with you in a little bit some strategies that we've used to overcome some of this. Some work better than others, but it was time to be creative. But when we think about behavior change, we're going to have another little pop quiz. Do you know how long it takes to change somebody's behavior? So those that think it takes 5 years to change behavior, hands up. Those that think it takes 10 years to change behavior, hands up. Okay, we got a little bit more. Those 15? Yeah, less. Interesting. 15 to 17 years to change behavior. So we're talking about practices that we know are best evidence, and it can take that long to change behavior. So in some work done by Carol Estabrooks, who did structural equation modeling, looking at the attributes that contribute to research use, there was one determinant, one variable that stood out in the model. And that variable, conceptually, is attitudes, values, and beliefs. So that's why it can take so long to change behavior. Because if you don't believe in something, if it doesn't resonate with your core of how you are, who you are, how you provide care, then practice doesn't change. I don't know how many years ago it was now, but many. We did a randomized controlled trial on the postpartum unit around umbilical care after birth. Do you use gentian violet? Do you use nothing? Do you use alcohol? Come on. Every nurse hates gentian violet. It's messy. It gets over everything. It's on the floor. It's on clothes. Nobody liked it. They didn't want to use gentian violet. Everyone was happy to do the study. Answer: nothing. Air drying works as effective as anything else and probably better. So we're in the process of getting a policy done. Practice changed before any policy got done because they were delighted to throw away the gentian violet because they believed that it really worked. We can jump ahead to something I'll talk a bit more about in a minute, another topic I love, fetal health surveillance, and tell you that we have level 1 evidence that's been around for quite a long time and a variety of clinical practice guidelines. And it's funny how those continuous monitors are still on the abdomen of most low-risk laboring women. And we know that they shouldn't be there, but they're still there because the same beliefs and values have not been taken up for most people in that area. So who knew that healthcare could be so complicated? Several years ago, we did a systematic review of strategies, and it was an area that we looked at in child health. What did we find? There weren't any strategies identified that were the most prominent, that were the most successful to use. And I'd argue that that is because each context is different. And I'd argue that a lot of times when we look at strategies for behavior change, we're taking them from a domain, from EPOC, the effective practices of organization of care. We're taking them from a place that is predominantly driven by a discipline, which is medical, physicians. Nothing wrong with that, but different care providers practice in different ways. What we need are strategies that are interdisciplinary, that work across the continuum. So I'm going to give you a little example. We did a study looking at ERAS, enhanced recovery after surgery, and we did it with the Urogyne population, and we were in a team meeting, and the manager and the anaesthetist who are on the team are having a little tiff, because the anaesthetist does not understand why those nurses don't go to the education session. Because she comes in on her day off, so why won't the nurses do that? And the manager is discussing with some heat the fact that the nurses do not have time when they're working on the floor to get away from the patient they're providing care for, because there's nobody to cover them, that when it's their lunch, they want their lunch, and on their days off, they want to be home, and they're not paid to come back in. And the two of them had a little go at each other, and then I stood up and I thanked them, and then they looked at me like I had 10 heads, and I said, now you get it. If we don't talk about our different ways of being and how we practice, we're not going to see that our cultures are not the same. That doesn't mean that we have to do everything in the right way, but we have to be creative about the ways that we're going to support one another to change practice. So when we think about who wants change versus who wants to change, there's a lot of difference. And we're not living in a society, in a healthcare environment, where we can actually afford to do what we've always done. And we certainly can't afford to do what we've always done because of what we learned in school, because that, for the most part, is all gone. We need a variety of tools, and there's a whole bunch of steps that we have to take. They will vary depending on where you're working. Some of them are common sense. Some of them are about people that know where they're going because of theoretical things, or also because of practical. But what we need to think about is, in knowing what you want to implement, first of all, we need to know that the unit is ready. And there needs to be an assessment done of readiness for uptake of something new. And I'll use an example, which I was going to talk about in a few minutes, but I'll bring it up now, and it is second stage management. So while there is varying evidence around second stage management, there is a clinical practice guideline that was developed by a group in Ottawa. And that clinical practice guideline was something that we used in a study to try to translate research into care. I went to the unit manager, and she was talking about the cesarean section rate and how high it is and what ways can we look at it. And I said, well, maybe if we gave second stage management some consideration, we could help to improve our cesarean section rate. And she said, no, I don't have time for research. That takes way too long. I'm going to start that. So I talked to her in April, and I said, okay, so this is April. So how about in September, when you haven't started it, you let me do some research. She said, Erna, come on, you know that we really need to look at this. The physicians are driving us nuts. We've got to get it done. I'm going to get it done. Well, you know what happened. September rolled around, nothing had been happened, and Erna got to start the research study that she did. One of the first in this particular form. So the IWK has a funding opportunity through the foundation, which is called TRIC, and is translating research into care. And in order to conduct one of these studies, you need a decision maker, a unit manager, and a researcher to be co-PIs, and then to bring an interdisciplinary team together. It's a great funding opportunity. So Jennifer and I started this particular project. But when we began it, the unit was ready. The conversation was ripe. They were talking about second stage management. They were talking about the cesarean section rate, and people were keen, so I thought, to do that work. Just want to give you that for some food for thought. But when we began the work to look at how we were going to make things, support things to change, and the concept that social professional roles and identity was one of our biggest strategies, things weren't working. So most of the research that I've done around knowledge translation is using time series analysis. So if we try to implement in a year, quarterly, we would try an intervention or two based on the things we found out through focus groups and interviews. Align a strategy at the end of that quarter or getting there. Look at the quantitative data to see if there's been a change. If there has, keep going. If there hasn't, put in a new strategy. And when there hasn't been changes and we've tried those strategies that were theory-driven, we tried some different things. So this could be a talk in and of itself, but I'll just share that the one on your right, that's Legos. I have a lot of them. And this is an activity called Lego Serious Play. It's used by many corporations internationally to bring people together in team building. And one of the things that is really important is while we do work together to provide patient care, we haven't often or do not often come together as a team to collaborate. So that activity is theory-driven, Lego Serious Play, and it has some great evidence with it to suggest that it can bring people together. I will tell you that there were people who told me they don't play, they don't like Lego, and I'm not going to sit for 8 hours and play with Lego, but I'll come. The room had obstetricians, gynecologists, anesthetists, nurse managers, students, nursing staff. Everybody used the Lego. Everybody enjoyed using the Lego. And the creative child at the age of 4 had no difficulty to play with Lego. And the more mature person at the age of 40 feels uncomfortable sitting next to someone playing with Lego. We lost something in our creativity wiring that I think we need to bring back. The middle image is myself and my colleague Brendan McCormick doing an activity called mirroring, and it's a dance. And it shows your comfort level with working with another without touch and without voice. It's hard to do, but it's something that promotes teamwork. And on the last are just a set of cards that I use to give people voice. If we sometimes ask each other to speak in an audience even like this, or even in a classroom, people are hesitant to use their voice for a variety of different reasons. But if we bring cards and we ask them to pick a picture that resonates their thoughts, they're far more likely to pick a card or a word to do that. And I've used them in many settings and happy to share more about it. The other activities that we've used are simulation activities with simulated patients. This one we did with a breastfeeding study. We used some of the examples that the staff felt were the areas that they needed support to enhance exclusive breastfeeding around with low-risk moms in the postpartum period. That was great to trial it out and then have people see and comment on the practices that we were doing. The other, although the full picture is not there, that's supposed to be an abdomen, and the baby's in the uterus. And in the challenge we had with the second stage study is that the healthcare providers weren't speaking with each other. So I thought I would go back to the sticker system, and every discipline had a different color. And whenever you spoke to a different discipline during second stage about the management and the care of that woman, including speaking to the woman herself rather than yelling at her, you got to put a sticker in that abdomen. Oh my goodness, the controversy that set up because people saw stickers of some color more than another and they wanted to see their color. Who thought that stickers would work with a group of healthcare providers, but they do. So there are, and we could take forever to talk about these things, so I'm just going to quickly go through them. A variety of current practices that we have where we are not using best evidence. Why? Why do we have support for breastfeeding that does not follow best practice? Why do we have moms in second stage pushing for the length of time they are, or pushing when they shouldn't push, being yelled at as opposed to being supported? And I am not saying that everybody does that, but it happens. I remember very clearly a particular woman that I was with. She was in second stage for 13 hours. And the reason she was in second stage for 13 hours was because she had a midwife. And it might just be that the other people in the environment that night did not want to engage with the midwife. And despite me charting to death about why nobody would come in the room, we waited. We had an okay outcome because women are pretty resilient. But 13 hours in second stage is really not cool. And we need to be looking at what are the reasons that affect us and impact us from doing that best practice. Oops. Let's go back one. My favorite, fetal health surveillance. For my doctoral work, and some of you know this, I looked at implementing the then fetal health surveillance guidelines from SOGC for low-risk laboring women. So prior to beginning that particular research, I did a pre-post with an interactive education session, because interactive education is reported to change practice between 5 and 14%. So I did, and I measured attitude. Just happened to be an instrument that measured attitude in fetal health surveillance. It's actually not a good instrument, but I didn't know that at the time. All of the nurses had the appropriate attitude. A year later, I redid it to measure attitude, and I looked at the practice. So when I began the study, when I began with the pre-test, protest, and the interactive education session, and I looked at uptake, and I looked at it every 15 to 30 minutes in the active stage of labor, what percentage of nurses on the unit followed the clinical practice guideline? Make a guess. Yeah? 5? 10? None. It was 7%. We did the study, 100 nurses later, percentage of uptake of the clinical practice guidelines. How much? 7? 6.8. Didn't change. So they had the right attitude. They had the interactive education that we know by evidence is reported to change practice, but nothing changed. There's many stories I can share with you. So I then moved on to do a randomized controlled trial where I mixed up paradigms and put an intervention in it called action learning, so that staff could participate in the process and come to monthly sessions to talk, nursing staff, to talk about their practice. They would get one-on-one coaching, and then they would go out and try to implement fetal health surveillance. I did not get statistical significance in my finding. The change in the unit was 6.8%. If I'd only said 5, I could tell you today it was statistically significant, but I picked 10. That's okay. What I did was I measured an outcome and not process. What I did was I tried to take an entrenched habit that people had done for a long time and change it. And what I did was I did research on one discipline. And it is not only nurses that provide fetal health surveillance. It's all of the healthcare providers in their circle of care. It's all of the people that they're working with. And so while I felt I was working with nursing, I will say that when people say, oh, she's a nurse researcher, I am a nurse who does research, but I don't do nursing research. I do the same kind of research everybody else does, and I do it with teams, because that's the only way that we're going to change care. We could talk long and hard about inductions, the different practices and policies that people have, the different preferences that people have. I believe there's evidence to support consistency. We don't see it. Skintoskin, we heard about it yesterday from our colleagues from Colombia and Sweden. We know the impact that skin to skin has. I can give you one excerpt. So different places do it better, worse than others. But I remember a particular anesthetist who shared with me one time, I can't stand that skin to skin. I get that hairy chested dad, and I've got to put that baby on that chest. It is so disgusting. So I thanked that person for sharing how they felt, because I thought that was pretty cool to be able to say it to me, because really. And then I said, but I would just like to remind you that that skin-to-skin stuff is in the mission and vision of our organization. I'd also like to remind you that you're a guest here because you're not staff, as a physician, and you don't have to work here. But if you want to go into that OR, that's how we provide care. And the blessing of being over the age of 50 is that when I'm 25, I couldn't say it as well, and I damn well can say it now. The latest work that I do is around women that live with obesity during pregnancy, birthing, and postpartum. It's a topic that we have not spent time considering with research across Canada. It is a topic and working with a group of people whereby their voices are not heard, their preferences are not heard, and the care that they receive is inadequate. The beginning of this work right now is doing systematic reviews, looking at not only the woman's experiences of living with obesity during pregnancy, birthing, and postpartum, but also healthcare provider experiences. And I think if we understand from where we came, we can talk about where we're going. But in the grand rounds I attended, one of the things that struck me and had a chord in my heart was that everything was what we have to do with these people that are obese. What are we going to do with these obese women that come in? Not remembering that it's person first, not remembering that it's not what we do to a person, but rather talking with them about the care that they would like to receive. And for some people who are blessed to carry some extra weight, they're healthy. And for some people who carry extra weight, they're not healthy. And if we look at the lens of obesity as a chronic illness, then I think we change the way that we provide care and the care we provide with these women. So pray for me as I submit for the third time my CIHR grant next month. I'm working really hard to have those that review see the lens of where I'm coming from, and it's a challenge. But grant or no grant, I've been very fortunate to meet a philanthropist who wants to fund my research, and she's going to fund me anyways. And it will be an opportunity. Yeah, thanks. It's pretty exciting. But it's an opportunity to begin the work both at the IWK and the hospital in Kingston. And then with that preliminary data, I would love to see us spread it across Canada. So stay tuned, because I'm not letting this one go. All right, I think I have to go a lot faster because I'm never going to get there. So the slide that I'm not going to go back to, I just said what influences your care. I'm going to ask you to think about that. I'm going to ask you to think about what are the things that impact why you do what you do. I'm not going to tell you that what you do is wrong, because you're all doing it for a reason you believe to be appropriate. But why is it when the mom is in labor, if you're able to provide one-on-one care, you don't sit at the bedside? Why do you put a strap around a low-risk mom's abdomen when you know, I hope you know, that you're increasing her chance for a cesarean section and a vaginal operative delivery? Why, when a mom is pushing, are we encouraging her in ways that are not appropriate? And who helps somebody get up every 2 to 3 hours in labor to pee? I don't even know that that's still happening, because most women have an epidural and then they get cathed. Why are we doing that when they can get up? So what are the things that impact where you are? And the next time you do something that's not best practice, don't beat yourself up over it, but take a breath and say, okay, next time I'm going to try it the other way. Just try it and see what happens. Maybe that can help us with our practices and where we're going. So there are the initiatives that we do are impacted by a variety of factors. And what I want to end with today is a few moments just thinking about being person-centered. We don't have time for me to go through all of this framework with you. We talk about being patient-centered. We talk about being woman-centered. We talk about being family-centered. I believe, so there's my attitudes and beliefs coming through, and I know, theoretically, that particular framework, sorry, it skipped ahead, enables us to have a healthful culture when we work with a person's beliefs and values, when we engage authentically, when we have a shared decision-making process between all those involved in that circle of care, when we're sympathetically present, and when we work holistically, having a context around us that is supported. Being person-centered, for me, is the umbrella of all of the other centeredness. But it is a way of being, and it is a way of working, and it's a way to remember that everybody, including the person who's the ward aide behind the barrier door who's not allowed out, makes a difference in the care that's provided to the next person to ensure that the room is clean. That it doesn't matter who we are when we work together, we all contribute to that care outcome. When we are engaged, when you experience that, there's a resilience and a willingness to work and an ability to even not be so fatigued when we can come together in that approach. But the one thing that impacts all of this is social professional role and identity. It's us having a conversation with one another about the care rather than rushing through the care just to get to the end. Of course, we can't do that unless we work together. And there's no effectiveness that has ever happened in anything unless we're working collectively and together to achieve that end goal. Communication, I cannot stress the importance of communication. Some units have huddles, and some of those huddles are just nurses. And that care is just not about a nurse. It's about every person that is with that woman, that person, when they're receiving care. And we need to have those conversations. And it's hard. So there are no easy answers to this, because some of the things, sometimes when I think them or say them out loud, I think, oh, this is such common sense. But we don't do it well. Everybody needs to have their voice. And that voice needs to be had not only by the care provider, but by the person receiving the care and their family. And when is the last time you asked somebody, is this the way you'd like me to care for you? When is the last time you said to the patient that you were providing care for, what are your expectations for your care experience today? What can I do to help you have a great day? It is not a difficult question. You know, when I ask moms in labor what are their expectations for the birth experience, it's bimodal. It's, oh my God, I want you to tell me every single thing you're going to do. There's that person. And then, what are your expectations for your birth experience? Duh, a baby? I don't want to know anything, just do what you got to do. Like, people are different. They want to have different forms of information, and we don't know that unless we ask. There are a variety of practices that get in the way of us being able to do that care, whether it's our trust and belonging, our values, or our respect, but there are so many complexities. And we spend so much of our daytime hours in our work life, then isn't that the place where we should be doing what's best for everybody? And depending on how you look at it, everybody sees something different. It really doesn't matter, because we do have a different set of lens. So let's just recap quickly. There's a bunch of things that make a difference. Our values, the leadership, trust, respect, communication, high support, high challenge, being able to question another person without them thinking, oh, she doesn't like me. Because it isn't about like, it is about respect and moving forward. If our values are, if we have a shared value in the work that we're providing, then when somebody does something outside of that scope, I can say, can you help me understand, Susie, why you did that? Because that's not the way we agreed that we would provide care. And if Susie and I trust each other, then it's all right to say that. If Susie can't stand me, then she's going to see that as a very negative thing. So it's how we're going to work it together. In our busy world, we go about the business of doing without being. We heard about vicarious trauma yesterday, about looking after ourselves. I can't repeat that any better than our speaker spoke. It's really important. And it does take a lot of work to maintain communication. And we have to hold each other responsible. So when I'm in the room continuously monitoring somebody, if the nurse that's outside who's responsible for the unit that night, or the physician that's coming in and out of the room doesn't say, Erna, take her off the monitor, that's not best practice. Why would I take her off the monitor? For those of you that have children, they're going to maintain the behavior that you know is not best unless you help them understand why it's not best. So we do have to help each other out. We need to collaborate, we need to be inclusive, and we need to work together. All persons in that context of care need to be included. They need to matter if we're going to flourish. I'll just let you read that. If we can be who we are and know that we can still flourish at the same time and still push boundaries that we need to push to do the best care, then that's pretty cool. I hope when I'm her age, I'm smoking that too. Change is challenging, change is tough, but if we don't look at it with a different set of lens and we don't really take the time to consider what it is we do, and for whom we do it for and with, then maybe we're not in the right place. So if we want to sustain it, the funny thing is we've got to keep working at it, and we have to check in with each other. And just like the research that I do, we need to continue to try strategies. If you want to change a pattern in your life, you need to replace it with something else. We know that. There's evidence to support it. And whether that pattern is eating healthy, exercising more, we need a buddy. We've got great evidence that peer support works. We need to communicate with each other. We need to hold somebody else's hand in order to make the difference. So when you go back to your place of work, whose hand are you going to hold? When something comes to us that we don't believe in, we want to push it away right away. One of the nurses in my doctoral work said, I'm just afraid the baby might die if I don't continuously monitor, so I'm not going to enter your study. That came from somewhere, and perhaps it was a past experience. So I asked her to don't do it all night long. Just do it every hour, and then put her on continuous monitoring for an hour. Try it. See if it works. See what it feels like. Rather than just going whole hog. The next day I got a phone call, oh my God, she didn't die. I think I'll enter your study. So people come with such a different lens. I've said this before, we need to work together and we need shared values. And with those things, that's the beginning step of all the different strategies and all the different theoretical bases that we can use to use best evidence in practice with and for the people we care with. So thank you very much. It's been a pleasure talking with you. I'm happy to have some questions and talk with you afterwards. Okay, so I'm going to ask you one, because we've got a few minutes and I'm not letting it go. What is the one thing on the area where you work that is not best practice, and why do you think it's not changing? But I see somebody up, so keep that thought in case nobody else gets up next. Hi.
Oh, thank you so much for a fantastic talk. My name is Tamina Ali. I'm a family doctor. And, I think it probably answers the question you just asked is, I think that one bad experience, like you showed the slide about skin to skin, and I remember trying it out in my rural practice with a C-section, and then that patient went on to have a really bad infection of the wound, and I couldn't help but think that it was linked, that we hadn't done it right, that it was the skin to skin, and then I was reluctant to do it again. And so it's those personal stories, and how do you overcome it? It's a challenge.
Yeah, I couldn't agree more, and those personal stories all make a difference. I mean, I can tell you for me, I fall back on what is the evidence, and I fall back to the place that if I know there is a best practice, then an N of 1 doesn't mean that that's what happens to everybody, but that care of that time and the event that occurs can hugely sit with different people in different ways. So I don't have an answer, other than the fact that you keep trying, because we know that skin to skin, as the example, does improve health outcomes of both the mom and the babe and the family. And an event doesn't mean it's every event, but when we look at litigation related to laboring women, it's there because people did the right thing, it's there because people didn't do the right thing. And for me, what sits in my soul is that if I know the care that I provided was appropriate, then when there's an untoward event, that happens. And maternity care is not an absolute of always a good outcome. And because we live in that place where we think that everything we do will always be perfect, it's not. And those bad things, sadly, are going to happen. But it's being able to talk about it. It's being able to share it with others. It's about having the reflection. I remember one night, I was in the early labor assessment unit, and it was really, really busy with us. It was really, really busy in the birth unit. There were 3 patients, and we were trying to prioritize who to take up to the birth unit. We totally missed the boat. There was a lady abrupting. She was what we thought was number 3. She absolutely wasn't. We did get her upstairs in time. Everything worked out, but it was scary and tense in the moment. On the way down in the elevator, I said to the nurse that I was working with, this is a great opportunity now for us to reflect on what just happened, to think about what we would do the next time, so we don't have to have those experiences. The response, That's that fluff you teach at the university. I'm not doing no reflection thing. So I know that not everybody believes that, but that reflection thing is what helps us grow. And you're having a negative experience. Maybe there was something you could have done different. I don't know. Maybe there was something going on with the health of either the mom or the babe that could have made the difference. But it's having the conversations about it and seeing time after time how that N of 1 might have been just that, an N of 1. So thank you.
If no one else has one, is there time for one more?
Yep.
I just wanted to go back to what you said about evidence is not research. Because I feel like a lot of the conversations we have, people pull out like their literature searches and fall back on that. And I kind of wonder how we continue to change the dialogue to those three triangles you brought up about, evidence and also kind of the social. And there was another thing, because I think that's what I'm kind of encountering. And some of the things that we're bringing up is that people bring up evidence as their armor of evidence going maybe against what you're saying, but there's other elements to knowledge, and how do you kind of combat that?
So research is evidence. It's one form. And so when I refer to evidence, I will say research evidence, patient experience evidence, care provider experience evidence. And the way to change it is to change the dialogue and keep having that conversation. Because most times when people say evidence, especially in a hospital setting, that is exactly what they mean. They mean research. But do they mean one randomized controlled trial? Do they mean one phenomenological study? That evidence is not enough. And I think it comes back, everything for me comes back to our beliefs and values. Because if you believe that the person that you're providing care for has a voice and that they matter, then that evidence is where you go. And if you don't agree with it, that's kind of too bad. If a mom many years ago, because I wanted to make some change on the birth unit, I wrote user-friendly summaries of research articles. And if you've ever done this, try writing at grade 9, 1 page, on a research article that you've read. It's really tough. But I did it around eating and drinking during labor. And there's lots of evidence for why there was, past tense, we didn't consume food during labor. Because gastric emptying is delayed, because women had general anesthetics, because statistically every 10 years one woman is going to die from eating and drinking during labor. So when a mom has an epidural and she's low risk and she's hungry and her body is working as if she's running a marathon, she wants to eat. So I tell her everything I just said. And I tell her what the research evidence is, and I tell her that the odds are she's not going to have a general anesthetic, and that she wanted to have an orange, that might help her. It's up to her. But this is what the policy is in the hospital, and this is what the evidence is. And just like what are your expectations for your birth experience, one woman will say, I could die, I can't eat, but she's got an epidural, mind you. The other woman will say, bring it on. So different people come at it from different places, and we have to remind that's what that evidence is. So thank you for your question.
Hi.
Hi.
I was thinking of a way of integrating your talk and mine, and I think it's about the nature of evidence.
Yes.
And the randomized controlled trial, which is considered to be the Bible
Yes.
of this, has been overrated. And when you look at a randomized controlled trial, you have to ask yourself, are the conditions under which the trial took place approximating my condition in the way we practice in our setting? And if it does, then that randomized controlled trial may apply to your setting and you could try to do something with it. But many randomized controlled trials are taking place in such a rarefied atmosphere that they do not represent what your practice is like, and therefore it doesn't apply. Right. This also applies to the vast use of meta-analysis. We all thought it was going to be easier to put a bunch of small studies together and they would become the ultimate truth. Well, obviously that isn't so, because each of those studies has its own environment, its own context. You have to figure out, this is very bad news. You have to read all those studies that make up the meta-analysis, and then you find out that some of the studies that are in the meta-analysis don't belong there, and other studies that should have been in the meta-analysis do belong there but weren't included, garbage in, garbage out. You just have to ask yourself again and again, are they saying something that applies to me? And it may, or it may not. And again, it's bad news because you have to take each of those very well constructed studies and say, does it apply to me? Do I practice that way? It's a lot of work, but it's absolutely necessary. Otherwise the use of these trials become problematic. There's also a lot of strange research that goes on. An obstetrician colleague of mine, now deceased, has a wonderful expression. Again, George will know him, but he says, we have learned to go from evidence-based decision-making to decision-based evidence-making. We have actually learned to construct the studies that will give us the answers that we wish, as opposed to the answers that we need.
Absolutely. Thank you. I love your comment. When in my positivistic view of the world, I am no longer positivistic, I did my RCT because my PhD supervisor told me I had to. And I did that RCT because that was the way that I thought that I would be accepted in the world of research, in the world of obstetrics, if a nurse did an RCT. What did I learn? I learned that if a group has to be blinded, do you think that when nurses go to break at night, they didn't tell each other what they did in the intervention group? Because I know they did. When almost 50% of the experimental arm dropped out of the study, that's a serious flaw with your study design. But I can't write and didn't write that they dropped out because they didn't like the nurse manager and they quit on the unit and went somewhere else. So when you do work that's pragmatic, there are places where you can randomize, the question fits, the design is appropriate for the answer you want to receive. And there are times where you have to look at the context and you have to look at the issue at hand and find the right way to get the answer to your question. And everything doesn't have to be research either. So I'll just remind you that there are a variety of quality improvement projects when we have evidence that we can use when we want to de-implement something. And I see someone standing there. Yes, hi.
Hello. Thank you for your presentation. What I wanted to quickly ask was, what was the name of the funding that you had to implement the study? I just wanted to...
Yeah, so had many of them, and it's called TRIC, T-R-I-C,
Okay.
and it's translating research into care. So the QE2 Foundation in Halifax, from donors, have that money to share to support healthcare providers to put evidence into practice. It's pretty neat. Yeah, I can tell you more about it. Thank you.
Thank you.
Thank you so much. That was awesome.